So let's turn our attention now to another patient group, Down syndrome, where a congenital abnormality results from an extra chromosome, and this can impact the biomechanical structure that results in an increased risk of developing compression to the spinal cord. Do you have some thoughts regarding this group?
Yeah, so there, at least when we went through our education in our school, they were the group that were alluded to in addition to rheumatoid arthritis, the rheumatoid arthritis group, but the Down syndrome group as a collective having the propensity to have an anomaly, so an abnormality in the ligaments structures at the craniocervical junction, rendering their upper cervical spine unstable as a genetic byproduct of that chromosome abnormality. And so they're a demographic or a group of individuals that have been studied as far as it pertains to some of the neurological manifestations that they have as being caused by the laxity that they have in their upper cervical ligament anatomy, causing brainstem irritation.
Yes, and the prevalence of CCI in this group of patients has been noted to range up to 63% in the literature of this particular patient group.
Yeah.
Next, let's talk about Ehlers-Danlos Syndrome, referred to often as EDS. In 2016, the Journal of Spine, Dr. Henderson referred to CCI in patients with hypermobility and connective tissue disorders, and this prevalence has been well documented. Moreover, the past few years, there's a clear understanding that's evolving that not every person in the EDS community will go on to develop CCI. However, if a patient goes on to develop craniocervical issues, this pushes the problem closer to CCI. That is, it's a contributing factor. And that was actually just discussed last week with Dr. Kaufman. So that last piece is Dr. Kaufman's words, not mine.
Mm-hmm.
Do you want to speak to this issue?
Yeah, absolutely. I mean, you can have a connective tissue disorder like EDS and not have CCI because ultimately EDS should be affecting the entire being. And, barring trauma to the cervical spine, I believe that EDS patients, so people who have the genetic version of EDS, because of the ligament laxity that they have globally, they're going to have laxity everywhere. But when you then add to that, mix a trauma that is focused, or the focal point of that trauma is the head and the neck, so either a concussive or a whiplash type trauma, because of the already lax structures there, you're going to have the ability or the propensity to have a more significant injury to the further injury, I guess, to those ligaments, resulting in CCI. So having EDS is not a sealed case as to you're going to get CCI. I think there are factors that come extrinsically to having EDS that would increase the risk, I guess. I don't think anything's certain, but increase the risk of developing CCI or AAI as a result of either a major trauma or multiple minor traumas that cumulatively summate to give you what would be considered a macro trauma, but yielding the CCI or AAI. Absolutely.
And I would add that if a trauma did not exist, or a series of micro traumas did not exist, what has pushed the needle a little closer for this type of patient? In other words, does infection or other play a role? And that's something that I've done personal research on as well. So it's just a question that perhaps this community could ask. So I want to speak about the overlap. Some neurosurgeons have indicated that EDS patients and ME/CFS patients are directing treatment in the same manner with regard to craniocervical instabilities. So I would argue that this brings this patient group closer together and patient groups closer together.
I definitely think there's a massive overlap between all the different named diagnostic conditions, which are often, like I alluded to in a previous session, labeled by the description of their symptoms as opposed to the causal tissue being diagnosed. And so I do think there's a lot of overlap that occurs between all the different diagnostic groups that relate to what would be deemed CCI or AAI.
Thank you. Next, let's speak about rheumatoid arthritis, which you alluded to, and systemic lupus included. Case reports in AME in 2021 detail autoimmune diseases that affect synovial tissue, which lines the joints and tendons. And the CCJ we know is made up of synovial joints and ligaments, which are especially vulnerable to rheumatic arthritic and other inflammatory processes.
Correct. Yeah. So the erosive nature of the inflammation caused by these autoimmune conditions, and I think they can all be lumped into there to a degree, but I think the most studied has been RA, rheumatoid arthritis, and I think lupus probably comes as a close second. But then you have Sjogren's, psoriatic arthritis, the ulcerative colitis, the group of digestive ones, ankylosing spondylitis, which technically fuses things but can also damage ligaments. Um, as a collective group, I think it's the systemic inflammation that causes erosion of ligaments. And because of the fact that the craniocervical junction is so relevant to body-wide functioning, because it does house the medulla and the beginning part of the upper spinal cord, the interrelation between that area being affected by the instability then or hypermobility that is caused by the erosion of the ligaments there due to these inflammatory conditions will result in neural compromise, I guess, resulting in a cascade of symptoms that, in addition to the RA, could be labeled as POTS or dysautonomia or MECFS or a number of other things.